Our next speaker, can you hear me? Yeah?
Yes.
Speaking loud is not usually what I do, but I'll do my best. Our next speaker is Dr. David Barile. He studied art and biology at the State University of New York in Purchase. He received a bachelor's degree in biology at the University of California in Santa Cruz, and a doctor of medicine at Eastern Virginia Medical School, and a certificate. He received a certificate program in bioethics and clinical humanities at NYU. His postdoctoral training included geriatric fellowship at Mount Sinai School of Medicine, internal medicine residency training at Beth Israel Medical Center, and family medicine internship training at Beth Israel Medical Center. He specializes in geriatric medicine, hospice and palliative care, palliative medicine, and internal medicine. He's board certified in all three of those areas. Currently, he teaches at UMDNJ in the School of Medicine. He's the medical director in the acute care for the elderly unit at the University Medical Center in Princeton, and the director of palliative medicine services at the University Medical Center in Princeton, and the director of New Jersey Goals of Care. Today, his topic will be updates in geriatrics and advanced care planning.
My colleagues didn't know I was an art school dropout, actually. And can everybody hear me okay? I'm used to speaking loudly. A lot of my patients are hearing impaired. And so at the end of the day, I go home and I've got this voice with my wife, and she's like, stop yelling at me. It turns out my wife is a facial plastic surgeon. I was going to bring her. Next year, if you're dissatisfied with my talk, then next year you can hear her. So you can imagine what the dinner table conversations are like. I try to help people age and die gracefully, and she helps people deny their age. Every day I come home and she's looking at my eyes. She wants to fix my eyes. But so I thought I would just speak for a while about, just for a few minutes, on updates in geriatric medicine over the last few years, what we've done at the hospital in the way of geriatric medicine, and talk a little bit about advanced care planning moving forward. And I don't mean any disrespect to my colleagues. I think they'll speak about diabetes and GERD. There's some very good research lately in the Korean American population that suggests everybody's going to get older. And so I think you'll be seeing more from me. I think that, but so I thought I actually made a list of things. There's so many. There are quite a few accomplishments over the last few years. So just so I don't forget, I have a list here. So I trained in medicine at Beth Israel in New York, and then I did a 2-year geriatric fellowship at Mount Sinai, and that was about 10 years ago. I've been working in Philadelphia over the years, and for the last 7 years I've been in Princeton. And in the last 3 or so years, I've been working really hard with hospital administrators and the medical staff on improving geriatric services for the seniors in the area. And it's incredible. In the last 3 years, we've gotten a lot done. And everyone warned me about working with hospital administrators, that they operate in dog years, meaning like everything happens really slowly in the hospital. And don't expect any big results soon. But it turns out they've been very receptive to a lot of the programs. And I think because they understand the population's getting older, we serve a lot of older populations. So I'll just list them. We created a year and a half ago a steering committee, a geriatric steering committee that oversees a lot of geriatric related programs. And we meet once a month to talk about anything related to geriatrics in the hospital and the community. And we have administrators, doctors on there, nurses, people from the community, and so on. Most importantly, they oversee the development of the ACE unit. Has anyone heard yet or has visited the ACE unit? ACE is acute care for the elderly. It's on the 2nd floor. The ACE unit started about a year ago, and the ACE unit is essentially a general medical floor in the hospital for the frail elderly. So what we've done there is we've created a safe environment, right, where a frail elder might come in from the community or from the nursing facility or from another hospital and get their medical care. What I mean by safe environments, right, we've created, the actual room is a little bit safer and better for orientation for the frail elder. We have big signage and so on. We have the way meds are dispensed is a little natural to the sort of course of the day. We try not to interrupt the sleep very much. We have multidisciplinary rounds there, which means throughout the week, we sit down at the table and I oversee multidisciplinary rounds with a nurse, with a physical therapist, with a pharmacist, with a speech therapist, a nutritionist, with a social worker, a case manager. So everybody that's involved in that senior's care throughout the day sits at the table and tries to coordinate care, right, to keep that person healthy and out of the hospital soon. What we know about older, frail patients when they're hospitalized and put in a hospital bed, they get weak very, very fast. So we think bed rest is a healthy thing. It's not healthy if you're an older patient. So what we want to try to do is mobilize the patient earlier, take the catheters out when we can, disconnect the IVs as soon as we can, and get them healthy and out of the hospital as soon as we can. And it's really been well received by the patients, by the physicians, and so on. What we've proven to the hospital, and we're very proud of this, we've proven that our length of stay, the average age on our unit is about 80 or 82. Our length of stay is shorter than the rest of the hospital. And not only that, the patients stay healthier out in the community. They don't come back as often. Our 30-day readmission rate is a little less. So it's been a very popular program, and we're hoping to expand it in the new hospital. The ACE units across the country, including ours, has been shown to reduce hazardous events in the hospital. So infections that are acquired from catheters, or falls, injurious falls when folks fall, and so on, less medications, and so on. So we're very proud of that. Also very proud about the geriatric emergency room we have planned for the new hospital. This will be just like the ACE unit, is this safe environment within the hospital for older, frail patients. We'll have a section in the emergency room that will be standard emergency room care, the same kind of emergent care that any patient might get in the emergency room, but a specialty environment for the frail elder. So better signage, better lightage, no glaring lights at the top of the ceiling, and so on. And also a pharmacist, a social worker that'll be there on staff to help coordinate the care and safely hand back that frail patient back to the community, even if they're not admitted to the hospital, to turn them over back to their primary care doctor. So we're pretty excited about that. We've created a section of geriatric medicine, and this is brand new. Just last month we've created a section. We have about 13 geriatricians on staff at the hospital, 7 or 8 are within the section. And this is really important because now we've got a body of people, several geriatricians that can offer advice to the administrators moving forward about geriatric care for the new hospital and so on. We'll have, probably with the move, the new hospital move, we'll have a 24/7 geriatric consultation service, which will be, I think, a big help for the medical staff. We've just received a grant from the Robert Wood Johnson Foundation, a $300,000 grant that extends over a 2-year period to help transitions of care for frail elders as they traverse the medical system. Most hospitals function in a kind of silo system, and maybe some of you experience this problem. You're in your doctor's office and you're sick, you're not feeling well, or your loved one's not well and they're transferred to the hospital. All this stuff happens in the hospital, all this activity, tests are ordered, blood tests are made, you meet all these new doctors, and then you're discharged from the hospital and you go back to your doctor's office or back to the skilled nursing facility, and nobody has any clue about what's happened in the hospital, right? It's just, you're sort of pushed off this cliff, and it's, so the lights are out. If you're in the outside of the hospital looking in, the lights are out. So this particular program called Transitions of Care will help smoothen those transitions, particularly for the most vulnerable, for the frail elders. And we're really excited about that. It's over a 2-year period. We've just extended it. We're probably going to extend it well beyond that. The person that received the grant money, a nurse practitioner named Kathleen Seneca, will be hired full-time to continue this once the grant runs out. Part of the Transitions of Care program includes something called the PULST form. Has anyone heard of PULST? P-O-L-S-T? PULST is a form, a doctor's order form, where the doctor writes down preferences of care for end-of-life care, for life-sustaining treatment. So PULSE stands for Physician Orders for Life-Sustaining Therapy, right? And this is a form that's actually portable across healthcare settings. So it's not legal in New Jersey yet, but in other states that have PULSE programs, and I can't name them all, there are about 10 or 15. One of them is Oregon, New York has one, California has one, but if the patient, let's say for example in Oregon, the patient comes into the hospital and has a discussion with the physician about what they would want and not want regarding life-sustaining therapy, regarding resuscitation or artificial nutrition and so on, the doctor fills out this order form, and that form is active in the hospital, active in the skilled nursing facility when they go over for rehab, and then active on the refrigerator door if they go home as an out-of-hospital do not resuscitate. So last year, State Senator Ruiz wrote a Senate bill supporting PULSE legislation in New Jersey. So PULSE is coming to New Jersey. The governor is expected to sign this bill probably in January, February. And what our hospital decided to do, and I'm very proud of our hospital for doing this, we were actually conducting a PULSE pilot as part of the Transition of Care grant. Our hospital back in March began using the PULSE form as a do not resuscitate form. We've tossed into the garbage our existing form, and we're just using the PULSE form. And we are the center of this pilot. And so I'm very proud of our staff. I think when the bill is finally signed, a lot of people across the state will look towards at UMCP for advice on standards of care and how to use this PULSE form properly. But PULSE kind of leads me into my next topic, and that's advanced care planning. And the PULSE form is a form that doctors are supposed to use for patients that may be entering their final year or two of life. And it's a form that asks about goals of care. What are your goals during the remaining time that you have? It asks about levels, scope of care, what kind of care you would want, full therapeutic efforts to prolong life versus things that may focus more on palliation and comfort. It asks about artificial nutrition. For example, if you ever had a stroke, would you want to live with a feeding tube through your tongue, right? And it asks it finally about resuscitation. If and when your heart stops, what are your thoughts about resuscitation, being kept alive, and so on? So it's an interesting form. It's sometimes awkward. It's often awkward to talk about. But my view about this form, the use of this form, is incredibly important because it really isn't just for that patient going off into hospice or dying. It's for that patient who really wants to take a grip on what's happening during their final time, to engage in decisions with the doctor about preferences for care during the final time. And so we can assure that their goals of care are aligned with available therapies. And sadly, what happens when any patient goes into the hospital, any hospital, sadly it's a one-size-fits-all model. You've come into the system and you get all of this care, and there isn't much attention paid to your specific hopes and goals for the future, particularly if you're entering during the final time. I should give, I'm going off, I'm distracting you a little bit here, going off on the side, but this is actually very important information, because most of us, I think, live in New Jersey. Now, it turns out that the average senior citizen in New Jersey, okay, the average Medicare beneficiary, is expected to spend more days in the hospital, more days in the ICU, see more subspecialty doctors, and more Medicare dollars spent than in any other state. New Jersey is 51st, last, behind every other state, including Washington, D.C., when it comes to end-of-life care, during the last 2 years of life and during the last 6 months of life. Now, here's a plug for our hospital. When you look at all of New Jersey, and you see how our hospital does to the rest, compared to the rest of New Jersey, we actually do pretty well with that. So, you may not end up in our hospital. I mean, you may end up in another hospital in New Jersey. My point is, if you're old and frail, it's pretty easy to get sort of sucked up into this system, okay? And doctors may order tests that are unwanted or burdensome. So it's important to talk about, and particularly important to talk about, I think, across cultures. New Jersey is the, I think, third most culturally diverse state in the United States. I don't know how many Koreans are living in New Jersey, but I know that Koreans are, I think, the most rapid growing Asian population here in terms of immigration to the U.S. But I've had a lot of Korean patients over the years. I've been in practice about 10 years, and just being in New York and Philadelphia, New Jersey, I've had a lot of Korean patients and relatives. And it's particularly important to talk about because it's an interesting topic, how people make decisions in the end of life across cultures. It's a very diverse state with regards to the patients, but also the doctors. I mean, you can look at who's up here. I'm a first-generation Italian-American. A lot of my colleagues, some of my colleagues are also first-generation Italian-American, but most are everything else, everything you can imagine. So there are a lot of barriers to having these discussions across cultures. What I've learned, my limited understanding about the Korean population or the Korean American population when it comes to advanced care planning and these kind of decisions. And this is what I hope to learn from you all. You thought I was going to come and teach you things tonight, but actually I'm hoping to learn from you all tonight. My limited understanding is that when folks are very sick in the hospital, if it may be an elder person that may be entering the final time, the decisions that happen around the bedside tend to be more family-driven. So they tend to rely more on what the family decides together and not necessarily what the patient, the voice of the patient, which is always important, right? But across cultures, that changes quite a bit. And so this is what I've learned. I've learned to not only discuss about advanced care planning with the patient, but also ask the patient if we should include the family members in the decision making and so on. There's not a lot of research on this stuff in palliative medicine or end-of-life care or geriatric medicine. I've come across over the years only a handful of studies on Koreans and advanced care planning, and with limited results, and because these are small studies. But what we've learned is that for the most part, seniors don't talk about their preferences of care with their children, and children don't talk about it much with their parents. So I don't know how many people came with their parents or with their children today, but I hope I'm not making you too uncomfortable. This may be something to talk about today or later today with your loved ones. Both parties agree that the patient's wishes should be honored. So that if you have a father and a son, the father, when asked, it's likely he'll respond that the son doesn't know about his preferences of care. If you ask the son may respond, yeah, I'm not sure what he would want or not want. But both would agree that the wishes should be honored for that patient. So it's an interesting dynamic, and I would love to learn from you all how best to generate this discussion within the Korean community here, how we can help with advanced care planning. But getting back to the pulse form is a doctor's order sheet. So this is something the doctor fills out as an order based on this discussion he or she has with the family, or after reading the written advance directive. So you should all still have advance directives. Who has a written advance directive, a living will, an instructional statement that actually 2 people in the room, 3 people in the room? So we should all have them. This is a living will, not a will after you die where your money goes. This is a living will, an instructional statement that tells the medical staff preferences of care. What will you want and not want if you ever got to the point where you could not communicate with your doctors, right? This is difficult stuff to talk about, but it's important stuff because of, number one, the problem with New Jersey, and number two, the importance of letting your family know about preferences for care. But the pulse form is a doctor's order that the doctor fills out based on what the patient tells them, or family member tells them, or advance directive tells them. So imagine a situation where I'm in the hospital and I have a person who may be entering a final time that can't communicate with me. My next step, the next step, is to ask the family member, where's the advance directive? This person can't communicate to me now. So we need to know about that person's beliefs, values, what would they want and not want. And if it's not there, then the next step is to ask the family member, what would they instruct us to do? Or what do you think they would want us to do? And that's a burden. I can't tell, across cultures, with everyone, that's a burden for a loved one to have to make decisions for somebody like that, to put in a feeding tube or not putting in a feeding tube. So this is why I think it's really very important across populations and with everybody. Yeah, I'll give you my own I often give my own parents as an example. My parents both immigrated from Italy, and they met in the Bronx. They married, and they had, I don't know how many years of marriage. My dad died about 10 years ago, and my dad had a metastatic cancer syndrome. My dad had melanoma, and my dad was the kind of guy who wanted everything done. Okay, this was a guy who got radiation to the brain, he got chemotherapy, he got a filter when there was a blood clot in the leg, he was in and out of the ICU, but my dad's goal during his very final time was to live as long as he possibly could, because my brother had young kids at the time. He wanted to see these young children coming in and out of the hospital room, he wanted to go to their baseball games and so on. And he knew he was dying, he knew he was entering the final weeks or so of life, but he wanted to stay away to enjoy all this. So that was about 10 years ago. My mom's still alive. She's got some Parkinsonism, but she still drives. She's in Florida now. She's doing really well. My mom has a written advance directive that clearly states if she has 6 months to live, she doesn't want to see the inside of a hospital. Right? She doesn't want to see the inside of the hospital. So the same people, I mean, they both came from the same cultures, met in the same place, same social circles, right? Pretty successful marriage. I think I would say, I don't know what my siblings would say about it, but I think they did okay. But two totally different opinions about care during their final times, right? So this is why it's really so important, I think, to get this stuff discussed within family systems, and also particularly important written down. So I think I'm supposed to stop now, actually. I'm sorry. Peter said, oh, you got 15 minutes. I was like, oh, I don't need that much time. I'd love to hear, during the panel discussion, I'd love to hear comments and how you can all help me help the Korean population.